of illness, which is people, who have a first episode of psychosis in the years beyond. Just as over the last decade, really, we have gotten interested in prevention in a more, primary, secondary prevention paradigm. It has become really clear that by providing optimal treatment early on, that it can make an enormous difference. And you're going to tell us about that. He's one of our child psychiatrists in our program.
So thanks, Dr. Frederick. My name is Yoshio Kaneko. I'm one of the child psychiatrists in the first episode and early psychosis program here at MGH. Oops. Left the slides for a second, but we'll get them back. Oh, yeah. Is that better? Okay. So I'm going to be building on what Dr. Holt introduced as the stage-based model of care and talking about some of the principles that guide our treatment in the first episode program. And those principles I can summarize, and we'll return to this over and over, but is the importance of intervening early and intervening well. Right? So those are the two big ideas that drive our program. So the first episode in early psychosis program was started in 2003 by Dr. Freudenreich and Dr. Cather. And before that, patients who were presenting with their first episode of psychosis, so the first time that they were experiencing hallucinations or delusions, were treated in the same manner that multi-episode patients were. But what Dr. Freudenreich and Dr. Cather realized was that this was a different phase of the illness. These patients were different, and they needed a different type of treatment. And so they created this program. What we offer in the program includes psychopharmacology, so medication management, CBT or cognitive behavioral therapy, family education and family therapy, group therapy, and case management. So what is it about the first episode of psychosis that makes it different from other episodes? Right? Why is this phase unique? There's a few main components of that. The first is that this is the first time that these individuals are experiencing these kinds of symptoms, hearing voices or experiencing delusions. They're brand new, as are their families, to these types of symptoms, and often brand new to the whole world of mental health care. And so, as such, they benefit the most from providers who are familiar with working with this specific phase of the illness, who are comfortable with talking about hallucinations and delusions, and experienced in walking patients and their families through conversations about diagnosis and about treatment planning. Second, there's a wide differential diagnosis for psychotic symptoms. Right? There are many disorders, bipolar disorder, depression, PTSD, substance use, many medical conditions that can cause psychotic symptoms. And so patients in the first episode presenting with this for the first time benefit from having providers who are familiar with understanding what is schizophrenia and what isn't schizophrenia. And sometimes that's really difficult to do, and often it's something that can only be done over time. But patients benefit in working with providers who are used to thinking about all of those different factors and what might be driving the psychotic symptoms. And then third, the first episode has unique treatment needs, and both in terms of how medication is used in this episode of the illness and in terms of the therapy that's done. So brings us back to the ideas of intervening early and well, and I'm going to talk those through in more detail. So intervening early. Dr. Holt mentioned the duration of untreated psychosis, the DUP, and we're going to talk about that in a bit more detail. And the other main thrust that drives us to want to intervene early is to minimize what we call the collateral damage of being ill or of having a psychotic episode. And so that piece, that collateral damage, includes things like the disruption and development. Right? So because this illness is often presenting in late teenage years or early 20s, that's a time of significant development in a young person's life, right? Often that's a time when they're living independently for the first time, making the transition to college and work, and establishing their identity, sort of who they are in the world. All of that can be disrupted by the symptoms of psychosis and being hospitalized and everything that comes along with that. And so by intervening early, we hope to get people back onto that developmental track as soon as possible. Both because of the symptoms of the illness itself and because of missing out on some of that development, there can be a great deal of social isolation in the illness, right? And people can get isolated from their family, from friends, and the symptoms of the illness itself cause a lot of suffering and risk of suicide and of violence, so like acting violently in response to some of the symptoms is elevated in that first episode. And so the sooner that we can get patients into treatment, the more we can curtail that risk. So that makes intuitive sense, and also there's data to back that up, right? So Dr. Holt showed us some of that there's early intervention is associated with improved clinical outcomes, and particularly, for example, in thinking about suicide or suicide attempts, the risk is much lower, 4% in those patients who had early intervention versus 17% in patients who are in sort of more regular treatment. And returning to the DUP, the duration of untreated psychosis, there's been a lot of research about this as well. So we know that a longer duration of untreated psychosis, so a longer time suffering from those symptoms before treatment is initiated, is associated with a poorer treatment response, right? So the illness is harder to treat the longer it's been going on, and is associated with lower functional outcomes, so harder for patients to get back to things like living independently, going back to work, going back to school. And a long duration of untreated psychosis significantly increases the odds of not achieving remission. And so when we think about remission, it's defined as having minimal symptoms for at least a period of 6 months. And that is both a worthy goal in its own right? So people are not suffering from those symptoms. And achieving remission has been shown prognostically to be associated with better outcomes, better long-term outcomes. So I have a little data up here to really emphasize this point. There was a recent meta-analysis, so an analysis that gathered data from many, many different research studies and looked at the correlation between duration of untreated psychosis and clinical outcomes. And you can see up here that for all of these measures, for positive symptoms, so hallucinations, delusions, negative symptoms, things like social isolation, hospitalizations, employment, the longer symptoms went untreated in that first episode, the worse the outcomes were. And conversely, the sooner people got into treatment, the better the long-term outcomes were. So I hope that by now I've convinced you that intervening early is important. I'm going to switch a little bit and talk about what we mean when we say intervening well. So there's been lots of research on treatment for schizophrenia that's tried to identify the essential components of the treatment. So what are of all the things that we do in treatment, what are the pieces that are the most important? And these components up on the screen are those. And in the first episode program, we offer a number of them. And we'll go through and talk about them in greater detail. So first is the specialized psychopharmacology, or the medication management. The key in medication management in the first episode of schizophrenia is not really exactly which medication you choose or is used, but rather in how it's used, right? So what we know is that patients in the first episode of schizophrenia tend to respond to lower doses of medication than patients who have had multiple episodes. And often those doses are as low as half of the doses that are needed in multi-episode patients. But at the same time, the patients in the first episode are more sensitive to side effects. And so we need to be careful about those side effects as we're using medication. And we know that patients in the first episode, the rates of response are higher than in multi-episode illness. So as high as about 80% in some studies. Next is cognitive behavioral therapy. So despite treatment with medication, there's a large chunk of patients, between a third to a half, who have some kind of refractory psychotic symptoms. So medication may lower the frequency, it may lower the intensity of those symptoms, but often patients are still having to manage some level of psychotic symptoms. And what CBT does is to give patients strategies for how to do that, right? So in the same way that CBT is effective for anxiety and depression and for managing those symptoms, patients can learn to manage the psychotic symptoms too, so that even if they're still experiencing them, they're not interfering as much with their life and their quality of life. One of the key things about CBT is because schizophrenia can have some effect on cognition and make sort of learning new things a bit more difficult, the structured approach of CBT is really ideal for making that therapy more effective. And I mentioned some of those strategies that are learned. I'll talk about a few others. So particulars of CBT might include things like helping patients to evaluate a thought to get a sense for whether this is reality-based or a delusion, and sort of weighing the evidence for that thought versus the evidence against it. It can also help to attack some of the cognitive distortions that happen, so things like black and white thinking or catastrophic thinking, where one thing goes wrong and you sort of expect the worst to happen. And by addressing those thought patterns, we can reduce the overall level of suffering. And then another key component of it is relapse prevention planning. So thinking through with patients and their families, what are the things that they can do or not do to try to avoid relapses, right? So we've talked some about the link between marijuana use and psychosis, and substance use in general and psychosis, so how do you avoid that? And also thinking through what are the early signs of another episode of psychosis occurring, so that if that's happening, patients can get into treatment as soon as possible. So another component of the treatment that we have in the first episode program is supported employment and education. So psychosis, psychotic symptoms can be a huge disruptor of somebody's ability to either go to school, learn the material well, and also function in a job. And so what a supported employment and education specialist does is to help work with patients to develop strategies to help them pursue their goals in that arena. And they can act as a bridge between patients and either their places of work or their schools, to help those places, to help the schools or the employers better understand what patients are experiencing, and develop accommodations that can help them succeed if those accommodations are necessary. So next is family-based treatments. Sometimes people ask, why involve the families? Why not just focus on the person who is experiencing these symptoms and remove the symptoms, and then everyone will sort of move forward? And I think there are really two main thrusts. First, just as individuals with the illness are grappling with these new symptoms, this new illness for the first time, families are also learning about the disorder and learning about strategies that they can employ to help their loved ones to succeed. And so, and the second part is that especially in our first episode program, the families are really a critical part of the treatment, right? So families are highly involved in helping patients to take medication regularly, to come to their appointments, to work towards their goals around school and work, and to think with the patients as well about that relapse prevention planning that I mentioned. So what does family therapy look like? In the first episode, it involves initially a lot of education, right? So education about what is schizophrenia, what are the symptoms of it, what might your loved one be experiencing, and subsequently working on communication strategies within the family, right? So there's a lot of data that shows that the more kind of conflict, the more criticism, the more hostility there is in a family's communication style, the more difficult it is for a patient with schizophrenia to recover. And so by working on those communication strategies, we can help support that recovery. Dual diagnosis treatment. So the rates of substance use in the first episode of Psychosis are high. They're typically about 30%. And we mentioned cannabis or marijuana already. That's often the drug of choice. And there's this narrative in pop culture or in kind of the community at large that marijuana is pretty benign, it's harmless, maybe it's even medical, right? And in schizophrenia, that's definitely not the case, right? So we were just talking about some of the evidence for that risk and how much of an additive factor that can be in terms of affecting the course of the illness. And when we think about treating marijuana use or substance use in general in the first episode population, we want patients to be working with providers who are comfortable in managing both the substance use piece and the psychosis piece and how those intersect. So we've talked about why we intervene early, what our thoughts on intervening well are, and what the components of that are. And now we'll look a little bit at the data for does this work or how does this work, right? And as we talked a little bit about before, there's lots of evidence that these kinds of specialized and early interventions are more effective than usual treatment. And how we see that effectiveness is a lower level of symptoms, right? So patients are less psychotic, fewer hallucinations, fewer delusions, fewer hospital stays, right? So less frequent hospitalizations, and often when patients are in the hospital, those stays can be shorter. And better functional outcomes, so better long-term prognosis in terms of living independently, working, going to school, those kinds of measures. As we dig into that data in a little bit more detail, I'm just going to show you a few graphs to really hammer that point home. So in this graph, the orange circles are the specialized treatment group, and the green squares are the regular care. And so you can see that over the course of the 2 years of this study, on the graph on your left, the specialized treatment produces greater gains and a higher ending score in terms of quality of life. So that's what that graph on the left is looking for. And on the right, the graph on the left is depicting negative symptoms. And so you see that the specialized treatment leads to a greater decrease and a lower level of those negative symptoms by the end of the treatment period. Similarly, specialized treatment has a really robust effect on relapse, so on another episode of the illness coming. at a year and a half, so after a year and a half of the specialized treatment, only 30% of those getting the specialized treatment had had a relapse versus close to 50% of patients who were in usual care. And those numbers are essentially reversed when we look at involvement in education or work, right? So 50% of patients in the specialized treatment group were working or were back in school, and only 30% of patients in usual care. And the substance abuse numbers reflect a similar pattern, right? So those in specialized care had a lower rate of misusing substances a year out, so a year into the specialized treatment. We've talked about family involvement and sort of what that looks like, what the benefits are, and have recently done some research on that in the population that we see in our clinic. And what we've shown is that for those patients who had families involved, the clinical improvement occurred faster, right? So we saw improvements from between year 0 to year 1, and which was not the case in those patients who did not have any family involved. So next steps, sort of where do we go from here, right? We've made some strides, right? I think that this idea about approaching the illness in more of the stage-specific manner is definitely good, and we're moving in the right direction, but there's much further to go, right? And when we think about, in our own program, what we're hoping for, I think on the research side of things, we're hoping to identify clinical factors, treatment factors, demographic factors that predict good outcomes so that we're able to replicate more of those factors in treatments for more patients and ideally pull those outcomes forward. And in terms of what we offer in the clinic, when we went through sort of what we offer and what's the ideal, a couple of things we're missing, right? So we're hoping to make weight management, because many of the medications that are used to manage the positive symptoms of psychosis can have adverse effects on weight, right? So we're hoping to integrate weight management and general health management into our clinic as we move forward, and to expand the offerings that we have in terms of group therapy, family work, and dual diagnosis treatments. So I'd like to acknowledge everyone in the program. You'll be hearing from some people later today. You've heard already from Dr. Holt, and we'll move forward to taking some questions.
Thank you.